It's Off Exit 10, presented by Capital District Sport and Fitness.
I can give you a little Adele. Hello.
Cool.
Nice.
Dude, we're rolling then. Todd, I appreciate you doing this.
Thanks. Great to be here.
Making room in your busy life to come over here and talk.
Yeah. Looking forward to it.
Your first pod.
First pod. I know. Let's go.
Welcome, man.
Let's do it.
It's an honor. Yeah, it's interesting because, I mean, we'll talk more about your medical background. But yeah, in terms of with the internet and society today, I feel like so many people consume their science and their news through, and we can just say science, since that's what we're going to talk about today, through mediums like podcasts and blogs and just quick snippets on social media. How much do people, I mean, a big part of your job is educating your patients, right?
Absolutely. Yeah. I mean, most of my patients now and most of the people I interact with have some level of knowledge that they've come in with, right or wrong. And it's my job to try and help straighten out what's valid, what's not, what's relevant, what's not. Mm-hmm. And I don't know, I come from a family of teachers, so I try and educate and do it in a way that helps move someone forward.
Yeah, so for the people listening that don't know you, I guess just explain, your background medically. And
Yeah, so I grew up around here. I actually went to Guilderland High School, ran track cross country there, and went off to run track and study engineering at North Carolina State. Go Wolfpack.
Big NCAA tournament this year.
Oh my gosh.
Both sides.
It's amazing.
they made it made it to where, the men's?
They made it to the Final Four in both men's and women's.
It was awesome. That was really fun. It's the first time in my life they've actually been really good.
Did you ever get the chance to go to any of the games?
Oh, when I was a student there, their home stadium was right on campus.
Oh yeah.
So you'd just go and pick up a $3 ticket and sit. And we didn't have great teams, but I mean, I came up watching Tim Duncan and Vince Carter and Anton Janison and
legends.
All these guys coming through the ACC and Duke and Carolina. Hated them all, but it was great. And so I had a great time there, but it was very evident that track was not going to happen well. I did not mesh well with the team's coaching staff. I stayed on for a couple of years, got hurt a lot, spent a semester in engineering, didn't like it, fell asleep in my classes and said I got to find something else. So I was 18 and 700 miles away from home and had to figure out what to do. And so, you meet with people and you kind of make a pivot. And I switched into biochemistry and figured I'd go to medical school, and fortunate enough to kind of keep the grades up enough to go to medical school. Went to Medical College of Virginia in Richmond. Had plans to go and think about orthopedics, and then spent some time doing orthopedics there as a medical student, and just did not love the OR. I did not love the sterility of it, the intensity of it. It stressed me out.
Too much anxiety behind it.
Yeah, it just stressed me out. And I was I kind of just really enjoyed interacting with people. Mm-hmm. And a lot of surgeons have to feel the most comfortable interacting with their patients when they're asleep. And I wanted my patients awake and interactive. So
yeah, good point.
So I kind of
I was knocked out for my Achilles. Yep.
Yeah. That's where they really are excelling.
Dude,
we know a lot of them. They're great. They're great people, but they still love to operate. That's their thing.
What year were you at NC State?
I was there 94 to 98.
Oh, so you just missed Jimmy V then.
Oh yeah, he was
there.
He was
till
just
19.
a legend. I think he was late 80s.
Yeah, he was 80s to 1990, and then
right. Yeah, he was still like the shadow
Yeah.
of him was there, but so their basketball program kind of fell on some tough times there in terms of the wins and losses after him.
I was trying to do the math in my head. I'm like, was he there when Jimmy V was there? Because that's a huge time of NC State history.
Amazing. And I mean, that's probably one of the most iconic college basketball videos
like ever
of that long, short 3-point shot that gets dunked at the last second to win the championship. So yeah,
that's really cool.
It's amazing. But it seems to be a recurring theme on here. It's like when you're in high school, you either think you know what you want to do, Right, and you're a prime example of I'm going to run track, I'm going to do engineering, and it's like then you throw yourself into that world.
Totally.
And I guess you're evolving and changing as a person too, right? You're
Yeah.
going from your teens to early 20s. You're on your own for the first time.
Right.
I think that's the big thing is like you don't have those outside influences.
No, right.
Like being able to be like, you should do this or you should do this. You can just be like, well, I really don't like this at all. So why am I doing this?
It's great to figure that out as early as possible, of course, but sometimes it takes a while. And I guess I'm perfect evidence that there are more than one right. There's more than one right choice, you know. And so I'm now in the age of having kids going to college, and I see a lot of kids in high school who then are getting ready to go to college and end up sometimes telling the story to kind of help alleviate anxiety of, you know, you don't have to, everything doesn't have to be perfect right away. You can make a lot of good out of whatever decision you make.
Right. The crazy part now is like it could be an expensive
Well,
it's an expensive decision.
Make your decision wisely about that, right?
Yeah.
So if you're really certain and that's a good one, then make that decision work. But if you're not sure, don't spend a ton of money to do it.
Right. So you quickly realized, I guess, as you were going through your rotations that you enjoyed orthopedics, but surgery wasn't for you.
Well, I didn't really know, you know, when you come out of that stage, you don't really know what else is out there. And I had been hurt a lot. I had been a runner my whole life. It really had, at that point, really defined a lot of who I was, and kept getting hurt, had a really terrible stress fracture that wouldn't heal. That was sort of the straw that broke the camel's back. And, you know, 6 months out of running and casted and dark times in my life. And I was, you know.
Stress fractures are a tibia foot?
Yeah, it was with my tibia. And they had bone stem on it. They were wanting to do surgery, and it didn't end up going on to surgery, but it basically took me out of running for close to a year. And I just never decided to go back to the team after that. But it was hard because I lived with a bunch of runners, and I partied with a bunch of runners, and I still hung out with a bunch of runners, and now it wasn't really defining me. So it's actually kind of interesting because at that time I also met a sort of my first, well, not my first, but a girl who was great, and we you know, sort of, she was not a runner and had her own set of friends, and we talk about it a lot now because we reminisce. And now we've been married 23 years and have 3 kids, and it's so another great thing that came out of going to NC State, but it wasn't the reason I went there. So, and now you kind of you think back and you're like, wow, that was what helped me not have running define me anymore.
Right.
And sort of being okay to move past that, and that somebody saw me as saying, you know what, it's okay that you're not a runner anymore. I actually like you better that you're not a runner anymore because you're not a jerk.
Okay,
right?
That's fair.
I'm very obsessive in what I'm into in my life, and it was baseball for a really long time. And I was like a, you know, middle of the road player who worked really hard to get to where I was. So I went to Springfield College, so a Division III school, and I played my first 2 years. I think I just put so much pressure on myself over the years that I got burnt out. I went to fall ball my junior year and was just like, man, this isn't it anymore.
Yeah.
Like, I'm not having fun. I'm really dreading going to practices. I'm thinking about I'd rather be in the gym, in the weight room, reading. But bringing it back, I was I'm married to my wife now who I was dating in college. I was a terrible partner when I was playing baseball because I was obsessed, and the pressure I put on myself, and I didn't perform well, and it affected other areas of my life. So it's like, yeah, man, that's real.
Yeah. And it's you know, it's an evolution of person, right? Like I pivoted out of that and got into triathlon towards the end of college and towards the end of college and getting into med school, and found I was pretty good at that, and I was able to stay pretty active and push really hard, but not run as much to avoid the stress fracture. And but then that came to being a big thing that defined me. And nowadays, you know, I'm fully aware that my fastest days are behind me, and I don't race a lot, and but it helps me relate to a lot of people in my life then who are either friends or patients or colleagues who have this thing that defines them, that really at the end of the day, nobody really cares. The only person that really cared was you. And, you know, So once you kind of start to learn that it's not what defines you, and you can let other things define you, or
your relationships with people define you.
Absolutely, and how people see you, and your ability to be there for the people around you and be present with them, that becomes the thing that defines you.
Is that ever hard for you in such a customer service heavy job that you feel like you're getting so drained, or it's so hard to turn it back on for your family? Not even turn it on, but just be super present?
That's a really good question. 100%. You have only a finite amount of bandwidth to be present and be around, and not even just the time, not even just the 168 hours in a week, but it's just the amount of energy and time. And so learning to say no to some things is one. I know that anytime you say yes to something, you're saying no to something else, and you may not know what it is yet, but when you commit to things a month, a year out, you don't know what you're doing at that point. So I try and have my internal monologue be, if it's not hell yes, the answer should be no. And so if things get really, something that's really exciting to me, absolutely, you don't want to miss out on that. But things that are, I don't know, then it should be no. And that's okay, because then you're essentially saying yes to something else that would have come up that day. Maybe it would have been, well, I can go to my kid's event, or I can get to a different recital or a different game, and maybe I can read an article that makes a bigger difference on somebody else that I see. Who knows? But you don't know. So there's a definite having to try and leave some of that at work. Mm-hmm. I feel like I'm pretty good at that, but yeah, like you come home and you're spent, and everybody's talking about their day, and they say, "How was your day?" And you're like, "It's fine." And
yeah,
you're kind of like,
it's good.
I don't really want to talk more about it. I just want to hear about how what happened with your chemistry test today, or what event are you running this weekend, or what time's your basketball game. And
yeah, the saying no is rare, though. That's something I've had to learn to get over, and I'm still working on over the years. Because we're running a small business now. I've worked commission jobs in the past where you have like this scarcity mentality. Because we were once at a point where like, if I didn't hustle this many people in the doors, we may not survive, or I may not be able to pay my bills. And it's like, okay, we're okay now, but deep in my head is like still that mic and still those feelings. And it's hard because like, oh yes, I'll do this, maybe it'll bring in that.
Yeah.
But it's like, dude.
Well, it's always hustling. I guess, right? And that's sort of, I think that I have an amazing amount of respect for small business owners who have that awareness to be able to select what is that thing that would make the most difference to you personally, but also professionally, because we don't all make the right decision. Sometimes you look back and you're like, ah, dang it, I shouldn't have made that decision. I missed out on a better opportunity or a better experience. I think that's why Warren Buffett only keeps a calendar of no more than 48 hours is what I hear. So if you want to meet him, he doesn't schedule anything out more than 48 hours because he doesn't know what he's going to be doing more than 48 hours from now.
Hey,
not bad.
I don't think I could live like that, but works for him.
It'd make me less stressed. I don't know if I could do it. But, okay, so I guess how'd you find yourself in your current position? Because I feel like it's unique what you do. I think you hear of somebody, I'm going, to an orthopedic doc, and they think, okay, you're going to do an MRI on me, and you're going to perform some type of surgery or maybe just get a cortisone shot. I feel like your toolbox is larger than most, or what you can provide. So let's talk a little bit about, I guess, the overall scope. So
after I kind of learned a little bit more in med school about what else was out there, I decided to go what we at the time were calling like the primary care sports medicine route. So I actually did a residency in family practice and then did an extra year of fellowship training in sports medicine. And then, so at that time I was in Northwest Pennsylvania in Erie, and stayed on and worked where I did my residency and fellowship for 2 years, doing sort of a mix of both. And then we decided we wanted to move back closer to where one of us lived. My wife and I at the time had just had our first child and decided all we did was travel to see somebody's family.
Yeah.
She had her folks down south in North Carolina. Mine were up here. And so we picked a spot and said, let's move back. And so in 2008, we relocated back here, and I worked a couple of channels of people I knew who knew people who knew people. And turns out that Capital Region Orthopedics was open to the idea of having someone like myself. They had one person already on who was part-time and doing sort of non-operative sports medicine and orthopedics. And so I joined in 2008 and have just built up the practice from there, starting with kind of knowing a lot of, techniques for rehab and exercise-based therapies, to understanding all the different roles that different modalities will play in recovery of injury, getting really a good diagnosis, and frankly, at the end of the day, just being more thorough about how you can break down somebody in not only just what's wrong with them, but why. And I think we are a little bit patting ourselves on our back here, but I think we're better at that. We take the time to do that, and it takes more time and takes more awareness and thought and history. So, and then, have kind of over the years built up a steady growth of what else I can offer patients to try and help diagnostically and therapeutically to try and help get them to their goals.
So it started with just going through an assessment, looking at them from specific joints in their whole body, and prescribing exercise. To, I guess, what did you branch out to next after exercise prescription?
Yep. So then I started this is about the time in the 2010s when musculoskeletal ultrasound was becoming more available and more aware, and something that became sort of standard of care and practice in orthopedics and sports med. So I took a few courses on that, found I was pretty quick learner on that, and just always had a pretty good ability to obtain and knowledge and understand anatomy, and that really helps. But it also helps with ultrasound, because then you end up using this point of care imaging device where you can look inside, see something, and correlate that with your exam, with your physical, and can actually see objective images and things, and then can, when appropriate, put medicine into a specific, very discrete location to help a condition, help a diagnosis, help understand it. And then as you get better that way, you start from going just with injections of easy joints like hips and shoulders and things like that, and going on to small nerves and small tendons and small ligaments and joints and structures that are harder to see. And you can actually treat people right then and there, and they can get immediate relief and get some sort of benefit. And also we can then understand a little bit more about their symptoms and what their condition is.
Right. So you're using the ultrasound primarily diagnostically at first?
It's both. It was both early on, because early on it was we needed people to have an easier ability to obtain an injection, say in their hip for an arthritic hip. Right. You could give it right then and there. You wouldn't have to go to the radiologist and have a CT or fluoroscopically guided
because
injection.
exactly what tissue you're putting this
Correct.
into with the ultrasound.
You can see it right there. You see the needle, you can see the vessels, you can see the nerves, and things you want to miss and things you want to hit. So so it started a little bit with both, and it still is both. But it's actually probably more diagnostic now, because that's the harder stuff.
Do you feel like you can now better, since you've probably looked at so many bodies and different joints and areas of the body with ultrasound, and probably seen so many different things, different traumas and injuries, do you feel like you now doing, whether it's like passive motion on a table or watching somebody's body move, be like, I've seen this before?
Totally.
And be able to make a better diagnosis just visually, because you've seen so many comparisons of how something moves and an ultrasound?
Right. Yeah. And it's funny, because I was laughing with one of the students the other day about how it feels like 90% of what you do in a day is stuff you didn't learn in school. It's stuff you learned after seeing patients, and after you see a ton of things over time, you get patterns. You've looked inside. Maybe you can take a look right then, and it confirms it. And then also it helps educate the patient. They can see. You can explain. This is your Achilles. Here's what a normal Achilles looks like.
Right.
This is what your Achilles looks like. Right. So you can help them understand that, and that's invaluable for that person's understanding of their condition.
Yeah, and to have it kind of be, people like things quick now.
Absolutely.
Right? So
People don't want to be said, here, you spent this time with me to try and figure you out, and then I'm going to come back in 3 weeks and we're going to do something, right? We try and get it done right then. And that's part of why I run behind, but sometimes it's worth it for people. So,
Yeah. So, okay. So in terms of injections, I mean, it'd be wet needling's a thing. And we've talked about dry needling, I know, when I met with you before.
So then after the ultrasound, we use that a lot early on, and still do a lot with, say, placing specific cortisone injections and whatnot for reducing inflammation or trying to create more space for different, conditions to kind of improve. But over the past several years, there's been even more movement in terms of some of the other ideas around pain and why do people hurt. And that's some of the impetus for why we kind of started doing a lot of what we call needling techniques. And it sounds terrible. I mean, no one likes the term needling because
I have a lot of tattoos and I don't like needles.
Yeah. They tell me it's different, right?
Yes, very much so.
Yeah.
A little bit deeper, Paul.
Yeah.
Either way, I don't like needles.
Yeah.
I would take 8 hours of Jesse on my arm, Paul, then like 2 needles into my upper trap. Like
I'll take 8 hours of that rather than watching you shove a giant needle like somewhere into my body.
I would argue, I think that watching it is harder than actually having it.
Yeah.
Like if you do it in someone and they have a family member or parent or something with them, a lot of times I'll say, listen, this is going to be harder for you to watch than for you to undergo.
When I worked in Massachusetts, physical therapists could dry needle.
Right.
It's allowed there. In New York, you have to be an MD or an acupuncturist, I think.
Yes.
Is that right, to use a needle? Yeah, so I would see it a lot. Like imagine, Pat was here treating somebody and he's working on an upper trap. And he's like, I just feel like I could get this trigger point or do this. Mm-hmm. And it's like, but needle. Yeah. So I saw it a lot more out in Massachusetts than here.
So then, if you understand a little bit more of the idea that not all the pain is coming from where they feel it.
Mm-hmm.
So, for example, someone who has, say, lateral knee pain that we might say is something like IT band syndrome, or someone who has Achilles pain, but their Achilles looks pretty normal. A lot of times that can actually be referred from what we call a myofascial trigger point in a muscle proximal or up above that area. So, for example, some of the most common ones is a medial gastroc calf muscle trigger point can give people recalcitrant Achilles pain. The lateral quad will give you lateral knee pain.
We have a lot of baseball players and volleyball players here. We see a lot of infraspinatus to the anterior shoulder.
Isn't it so interesting, right? So that posterior delt and posterior infraspinatus muscle has definitely a referral pattern to the anterior shoulder. Mm-hmm. And so I see a ton of people that have been told they have a biceps tendon problem, but then you do their biceps testing and it's normal. They just have pain in the...
And you go back and you palpate just like that medial border, that scap, and you hit that band and they go, that's it.
That's it, man. Yep. Mm-hmm. So as you become more comfortable with that, early on we used to just say, okay, get a lacrosse ball, get somebody's elbow, get a massage therapist, maybe get some acupuncture. But now with the sort of more availability of doing some needling, it's a really benign procedure. It doesn't really hurt that much. It's very repeatable. It has super low risk. And so I do a ton of that every day. And you get almost, a lot of times you get immediate feedback. They say, well, that spot's sore, but my pain is gone. You're like, all right, in about 24 hours, that soreness is going to be gone and you're going to feel a lot better. And that, works wonders to try and really help facilitate the PT to try and then deal with the other, kinetic chain issues that are probably why that condition developed in the first place.
Yeah, that's so important. Like, why did that trigger point form in that tissue to begin with, right?
Right. So, I mean, the kinetic chain idea is one that's always been sort of used for a long time. I mean, nowadays there's that sort of newer age term of biotensegrity, which is biologic. It's a merging of words, tension and integrity. And it's basically saying that everything is connected.
Yeah, like I went to massage therapy school. So like Thomas Myers was a big guy that you would read.
Yeah, big name.
Yeah.
Yeah. So he's sort of pushed that pretty well. It's still a word that it's hard to, it's kind of hard to understand fully, but, in a nutshell, right? So if people understand that their pain isn't only where they're feeling their pain, they're a lot easier to treat and to buy in and to understand why there's got to be some work, that you can't just snap your fingers and make something go away.
Yeah.
And maybe, if you do needle it and they get better, that's great. But then if you don't deal with that biomechanics that got you there, then you're going to have it come back.
Is that why low back pain is such a tough thing for people? Because there's so many variables?
Absolutely. I think that low back pain, you've got just such a vague amount of symptoms and such a variety of things that can be pain generators.
Yeah.
Right? You've got disc, nerve, joint, muscle, tendon, ligament, and then you get into the abdomen and the pelvis, and there's all these different levels and layers. And I mean, low back pain's tough because we really, frankly, don't always have a great test to be able to know what it is that's causing.
Or you could have a structural issue like a disc, but maybe that's not the main player of your symptom.
Right. So there's plenty of literature looking at asymptomatic disc herniation. You take people off the street with no back pain, 100 of them off the street, 48 of them are going to have a disc herniation, but no symptoms. So, I mean, one of the things I do a lot with low backs is, for needling, I find the upper glute is a huge referral source for people with low back or what they think is like a sacroiliac joint problem. So sometimes we're needling their glute med, their glute max. It's super easy, super quick. I do it a lot in a lot of my athletes, and then they end up coming back and then coming back and coming back to either have it done more or have other areas done because that got better. And especially people who are, just higher tone and, very active, doesn't matter what age, done a ton.
Do you feel like a higher tone person, a tighter person responds better to this type of treatment than somebody that has more laxity and is more hypermobile?
I do think so. Yeah, that's a great point. I think, and I don't know that there's I'm not aware of any study looking at this because it's something that would be hard to quantify, but certainly people who are less, the less flexible, the really, the ones that you say, wow, like feel that IT band, it feels like a guitar string, right? Versus the people who are, easily able to place their palms flat on the floor and pursue a ton of yoga and are really hyper flexible, mobile, and they pay a lot of attention to that. I think they still can benefit from it. But I would say the recurrence and the rate of return is probably a little lower.
Right. The supplement industry is like the Wild West. The lack of regulations mean the supplements you purchase may not even contain the ingredients listed on the label, which is why I get my daily vitamins and supplements from Thorne. Thorne vitamins and supplements are made without compromise. Quality ingredients ensure your body optimally absorbs and digests your daily supplements, while in-house and third-party testing ensure you're getting exactly what you paid for. Thorne offers a variety of health tests reviewed by board-certified physicians that evaluate your lifestyle, gut health, sleep, stress hormones, and metabolic markers to determine which vitamins and supplements may be most effective in helping you feel and perform better throughout the day. For college and professional athletes, Thorne has NSF-certified supplements that make sure you won't get pop positive on a drug test. Whether you're an athlete, professional, parent, grandparent, or weekend warrior, Thorne's selection of high-quality supplements can help improve your quality of life. Switch to Thorne's high-quality and extensively tested supplements today at thorne.com/u/CDSF. That's thorne.com/u/CDSF. This episode of Off Exit 10 is brought to you by Bombas. Bombas makes my favorite pair of socks, hands down, alongside the most comfortable and durable underwear, t-shirts, and other everyday clothing staples. Their wide variety of sock lengths, colors, and patterns have you covered, whether you're working out, going out, or lounging at home. I love their merino wool blend athletic ankle sock for long days of coaching at CDSF and getting in workouts myself. And if I'm at home doing work around the house, you better believe I'm wearing my Bombas Sunday slippers with their comfy memory foam midsole. And when you buy from Bombas, you're also buying for those in need. For every item you purchase, Bombas donates one item to people in overnight shelters, transitional living facilities, rehab centers, Title I schools, and medical service professionals. Take my word, if you want to upgrade your sock game to one that's more comfortable, durable, fashionable, and charitable, head over to the Bombas link in this episode's description to browse their full collection of everyday wear, and don't forget to use code CDSF20 for 20% off your first order. Yeah, I mean, Paul, think about somebody in here, like on more of a macro scale and movement. Yeah, if somebody just, is symptomatic somewhere, let's say their hip joint, and they're tighter, they're a higher tone person, we're probably going to spend more time foam rolling, stretching. If they're a looser, more lax person, probably more low-level stability drills, and then, progressing that.
I mean, I just think the difference, if we want to bring it even simpler for us, the difference between like a middle school girl that comes in here that needs to be more stable to a junior football player that literally
has been powerlifting
for the last 4 years.
Right.
Like, he's probably going to see a little bit more benefit from the needling than like the girl that's super hypermobile.
Yes and no. Okay. I mean, I think that even hypermobility, because what ends up happening is they're hypermobile in certain areas, but then...
Do you think they're laying down trigger points somewhere to create stability?
Yes. So I think that they compensate by, and then that's often what brings them in as their pain generator. People don't come in and say, I'm not happy that I can't reach my toes. Right. People come in and say, my shoulder hurts or my butt hurts. And so those trigger points or those spasms are what cause the pain. That's what often gets them to go from seeing you to seeing me, right? They want to see you guys because they want to be stronger, they want to be faster, they want to be better, they want to stay healthy. I don't see that many of those. I see people who are coming in because they either failed that or are hurting. And so I think that those hypermobile people, for example, if they have hypermobility in their shoulder, for example, and they're a swimmer, and or a volleyball player, somebody who's getting into this position of drastic instability of external rotation in their shoulder, then a lot of times they'll develop a posterior delt or a teres trigger point. Sometimes even anterior, or referred to the anterior from the posterior. So and sometimes lats, and they get this sort of hyperspasticity in a specific location, but they're still really mobile in other ways. Right. So you have to kind of that's where it gets challenging, and where it helps to have good biomechanical people working with you. That's why it takes a team. Man.
Yeah, and assessing you as a whole person and looking at different joints. I think the hard part is in our med system, somebody may have shoulder pain, go to a doc, okay, image is clear, or okay, I see this. But it may not answer why, or may not put them on the right path. You agree?
Right, absolutely. And that's where I spend a lot of my time. Is a lot of the people who are seeing me are people who've been through the system. Every day I'm seeing third, fourth, fifth, sixth opinions of people who've traveled all over and been to different specialties, and they haven't been able to crack the code. I'd like to think I'm above average at that. It's just one of those, but if I can try and move things forward a little bit and try and help them understand it, try and help them stop floundering through the system, because sometimes we're not great at that.
You know what a tough one is for us? We've had people come to us that have kind of floated through the system, is getting like a thoracic outlet diagnosis. Have you seen those? So
thoracic outlet syndrome is a toughie, because I feel like there's it has seen me more than I have seen it. Right. And so, because it's not always the first diagnosis you think of when you've got someone with, a dead arm or an aching shoulder, an aching, elbow, and there's so many different ways it can present.
Yeah, and we see it a lot. Let's say baseball athletes, you see a lot. So you think of, oh my gosh, is this the elbow joint and a UCL? Or sometimes guys are like, dude, I don't have my feel. My location just isn't right. And you go, oh, you just have the yips. But
right. And so you got to get good at hearing the complaints that they say, because it's not always pains or weakness. Sometimes it's heaviness, it's numbness, it's a lack of control, it just doesn't feel right, and it's all these vague terms that you've got to kind of say, oh, okay, well that's interesting. And it may bother you at rest. It bothers me when I sleep. It keeps me up. There's different things that that they're gonna wear a lot of different hats and masks that sound different. That's what's fun, right? I think that's what's exciting. It makes it challenging. It's not just this formula of XYZ. It's all these different little decision paths, and that's why I think I have enjoyed coming back to like what I do. That's why I think it's great. I do something different every year. I add something new. And
do you feel like your engineering brain is still there? Like you're methodical, you're analyzing?
Probably, although I don't think I ever really had an engineering brain. I was following my dad's footsteps.
Oh, okay.
He was an art engineering professor, and so I was like, I just want to be an engineer, just like every other, like 15-year-old kid who, liked what his dad did.
Yeah.
So, but no, I guess maybe, but I don't know. I'm not thinking that way about like trying to build something or fix something. I'm trying to think of the body as a unit, but it's, and then where does this psychological part fit into there?
I mean, we started talking about pain. Like you get into the pain science portion ever, like the David Butler, or like the Mosley stuff.
Yeah. So you have to address and validate, right? And that's where some of even the best docs are great. They want to try and diagnose, but they're sometimes that diagnosis may be elusive in the way our current imaging and diagnostic systems operate, and so then that almost invalidates the patient's pain if you can't give them an objective answer. Well, here's this tear, here's this break, this swelling, so then that doesn't validate their pain. They say, well, I must be crazy. I don't know why I have pain. Well, no, you have pain. It's okay. We just haven't figured it out yet. And so that's what's great is if you can help them a little bit with that, it buys in everything else, and then it makes it a lot easier to get people to buy in on what you're trying to propose them, which is often very abstract.
Yeah. Do you feel like with somebody who is in more of a chronic pain situation, you go, well, I got to get them to trust me. I got to get some buy-in. I got to build a little rapport to even have a chance to make this successful?
Yeah, that's why I like the phrase, don't let perfect be the enemy of good sometimes. And so if you can get someone in there who, if you can just, you don't have to slam dunk. You don't have to kind of cure everything right now. But if we can get a little nudge closer to being better, sometimes, even just a little bit, they'll really trust you. And because, it's a relationship you're developing, and everybody is walking in with their own baggage, with their own story. And that's what makes things so hard, because you don't know their story.
Right.
And, in this day and age, I've got, the way my schedule's built, it's 20 minutes for a new patient appointment.
Is that really hard for you sometimes?
100%. If I had a magic wand and I could see, 8 to 10 patients in a day and spend a couple of hours with the person who needs a couple of hours, 100%. But the way everything is built these days, it's not a reality right now. And so you get good at the shortcuts of being able to, cut through some of the chase and getting to the really important stuff, but knowing when it's okay to say, you know what, I'm going to sit with this person for another 15 minutes and just listen to them and just run another 15 minutes behind and develop that relationship, because sometimes that can be the thing that really gets them to let you help them. And it takes time, it takes patience. And like I was saying earlier before we even started, it's like you got to make sure you've got your compassionate hat on, because sometimes you're tired, sometimes you're burned out, sometimes
I didn't have my compassionate hat on this morning, Paul.
No, he didn't.
Not at all. I usually do, right,
Yeah.
Paul?
Usually didn't this morning.
But don't you guys have to also be a little bit sort of drill sergeant-y too.
There is a happy medium.
It's person specific, right? We have adults in here. They want to get comfortable in the gym. They're a little nervous. They've had a past injury. So I want to build them up, make them comfortable, be empathetic. It's hard. That middle school boys are my downfall, dude. One this morning
Thank
came
God
in.
Mike didn't have a boy.
Came in, dirty shoes. I look around. There was just dirt patch, mud, dirt patch. I went over, I plugged in the vacuum, and I said, here you go. Vacuum the turf.
Here's your warm-up.
That's essentially what it was.
But yes, we do.
You got to have that happy medium, and and then it's just also understanding person to person, and understanding body language and how they say something, and all of those things. And within that 20 minutes, like that filter you have in your brain has to be super fast for that in that 20
Absolutely.
minutes. Whereas we have, when we meet a new client, I have an hour with them. And if I really need to stretch it longer, I just tell the guys like, hey, I got to stretch this a little bit longer. And we can.
Yeah.
You don't have that luxury.
Right.
And so you got to have an extreme filter to be able to be like, okay, I see this. This is their body language. This is that. And that's all happening all at once.
Right.
And for us, it's like I told you before, we train in small group. And it's like semi-private. So everybody has their own custom program. But we're kind of, one or two coaches, depending on how many people are here, are bouncing around coaching them. So we not only have to scale how we coach and how we program exercises so people can get the same experience, whether Paul's coaching them or me, we also have to communicate on people's psychology, where they're coming from, past traumas, what's going on in their life, because that can impact the session, clearly. So if I know somebody's parent isn't doing well or something's going on with their kid, like I got to make sure I relay that to the guys so that they can then be empathetic, listen, ask them about it when they're in next, if I'm not the person here.
Yeah, that's so important. And I mean, we do that all day, and we're not that different, you guys and me. I guess I just have to do it in a little bit quicker and shorter fashion. But that's, you can't let that stop. You have to just keep with it and then say, well, maybe we'll get to the next piece of it because we spent extra time trying to understand each other today and where we're coming from. So we'll get to the next time. So then you chip away at it.
And usually in that sense, like if you spent that extra time and you took that time to get to some sort of root of what's going on, they're going to be receptive to being like, okay, I'll come back.
Yeah. Like here's a new way to think about this.
Rather than like, hey, I want it now.
Yeah. Yeah. I mean, everybody wants everything done yesterday, but sometimes just adjusting that expectations and making sure their expectations are congruent with reality and helps them trust you. And then you say, listen, if this is even just a little better for a period of time, that's important. We can build on that. So,
and if somebody's got to vacuum the floor that day, they got it.
You just make sure you plug it in for them and be like, here you go.
Yeah.
I was nice enough to plug it in. I turned it on for him, just handed it right to him.
I'm just glad you plugged it in since you didn't plug the fan in to make sure that worked.
Well, a similar story. I remember a number of years ago, I had a patient in the room waiting for me, and she was clipping her toenails.
Oh, whoa. Hey. Oh, I hate feet.
Yeah, I hate feet. That's already a red flag.
I wish I had a vacuum. I could have just given her the vacuum and said, thanks. Thank you for cleaning up after yourself. When is that an
appropriate thing to do in public?
Yeah, never.
Sandals on, or they took the shoes off?
I don't remember, but she was sitting in there with her bare feet on the table, and I just hear it as she's clipping away, and I came into a little pile of toenails on the floor. Seriously, that really happened. It's a long time ago.
That creeps me out.
Yeah, that's disgusting.
You guys have mud on your floor. I have toenails.
I'll take mud all day.
Yes, please. Vacuum up your toenails.
You guys can bring in the mud. Don't bring any toenails.
Yeah. Just do that at home. Do it on your own time.
Oh, dude. Okay, going.
Sorry on that.
That's disgusting.
I just had a mental picture of somebody like in a doctor's office, just literally, and everybody just looking at him like,
what? I even called her out. And I said, "What made you think that was a good use of your time here? Like now I have to have somebody come down and clean this room up before anybody else comes in here." Oh, I'm sorry. Oh my gosh. Yeah.
Oh, dude. Yeah. Listen, we see
people do some weird things, man, at the doctor's office.
People tell you some stuff too, probably.
Oh, yeah.
We don't need to get into it. People tell us some stuff, Paul.
Yeah.
Oh man.
Yep.
There's one client of mine in the past in New York that I remember. Great guy. I loved training him. But man, I know way more about his life than I ever should.
Yeah.
Way more. Way more about aspects of his life that I should never know. And you know what? That's just the way it is. And we had a good rapport, and that's why
You're building
he
rapport.
stuck with me for a long time.
Yeah.
Yeah, that's real. Okay, going back to science. Foam rolling, what's the mechanism that's actually going on to give somebody relief?
So I think that going back to some of that, the idea of like a trigger point, right? So the understanding of a trigger point to me is that it's some form of dysfunction of what I call the neuromyofascial unit. And so that means the fascia, which is like the skin of the sausage around the muscle, and the nerve tissue that's in between the fascia and the muscle itself. And so, and it can be any or all three that can be causing that pain. Now, if you, there's more than one way to try and get at that. Now, foam rolling, in my understanding, would be a way to try and disrupt and mobilize the fascia over the muscle. So it's not compressing that nerve tissue, or what we call the nervi nervorum. It's this little spider web of nerve tissue that's in between the fascia and the muscle. I think there are times where, if you're good at tolerating pain and taking a roller, and you can probably try and disrupt some of those trigger points from a muscular standpoint. Those are those little knots that you roll over, and sometimes you can get them to break up. Those are the things that you would do some needling for if appropriate. And then on the same realm of that fascia and the foam roller is I will, if they don't respond to that needling, I'll often do like a fascial, what I call hydrodissection, where you can actually use an ultrasound, find that layer of fascia, and inject fluid in between that fascia and muscle, decompressing that area that is probably causing some of their pain. And so, because by the time most people are seeing me, they've already been foam rolling, right? They've seen 3 physical therapists, 2 personal trainers. They've come in with a bag full of torture devices, the hip hook, or, these different, myofascial release tools.
Everybody has a massage gun now.
Oh, and everybody's got a Theragun or some sort of pistoning device, and I think they're all valid. I think they all work. I mean, we have one at home, and I have a couple foam rollers. I mean, I do think they have a good maintenance role in terms of staying flexible and keeping that fascial plane sort of flexible. I think it's sort of similar to like your Grastenine and your sort of external stimulation devices of trying to disrupt that plane and mobilize layers of that fascial tissue over each other.
Does cupping work through a different mechanism because it's not so compressive, or probably the same?
I think of it as the same way, because you're using vacuum to try and separate layers of tissue.
Right.
It's sort of a dull instrument, in terms of its precision, but I think it has some role and has some relief, and a lot of people swear by it. I've had it done to me. I've had a lot of patients have it done. I don't know that much about its use and when it's inappropriate or appropriate, to be honest.
Right.
But
okay, so going back to needling, when you're injecting a medicine or into somebody, what are the different options that you have to choose from?
Right. So, I mean, needling, when I'm doing it, vast majority of the time, I'm doing a form of what I call therapeutic needling, which is a use of a needle and a small amount of fluid. Usually it's a combination of a small amount of lidocaine, and it's diluted with something called D5W, which is a 5% dextrose sugar solution. So there is a method to the madness here, in that it's lidocaine does seem to help with the pain afterwards. And there is some data looking at using dry needling versus wet needling. They were terming it wet needling. I just thought wet needling sounded weird, so I call it therapeutic needling. And the lidocaine seems to help with the pain afterwards. And then the D5, there's some thought that might actually cause some reduction in the nerve hyperexcitability that goes along with this. So it's not a lot, but it helps. And that's what I'm often using when I'm doing an injection into and around someone's fascia. When I do needling, I don't use any corticosteroid. I don't use any cortisone. the mechanism is different. You don't need an anti-inflammatory, and then you don't have to worry about the side effect of the corticosteroid. Still do a lot of cortisone injections for the right reasons. Some people who have inflamed joints or inflamed tendon sheaths, inflamed nerves, nothing's better at getting that to be relieved quickly and efficiently than a corticosteroid injection.
Is it a real thing, though, where if you have cortisone in the same tissue over time, it can wear it down?
Yes. So, I think that has been shown for sure in literature especially in soft tissue tendon injections. You will cause increased risk of recurrence of that tendon problem. You can cause increased risk for tendon rupture if you put it into or around the tendon. And then it can cause accelerated cartilage damage if you're injecting it into the joint. Now, that said, if that injection allows mobility and motion and allows you to be better at regaining a normal functioning joint, then it's worth the risk of a isolated or using, because I think you got to be careful of making sure you try and use those injections as a tool to facilitate an end, not in just being their own treatment.
Right.
So if you use that and then they are able now to walk more or ride a bike more or be more active, that is going to be much, much, much more beneficial to the joint or the tendon or the tissue than the detriment that you underwent from the injection. I think
it's allowing them to take that next step to be more active,
Correct.
Whether it's aerobically or like now you can start your PT program and do this more effectively.
Correct. Yeah. So where it becomes challenging is if they need more time than is provided by that injection. What do you do with those patients who come back 3 months later and say, wow, it felt great for 2.5 months. What can I do now? And so you have to make sure that they're doing their homework. You have to make sure that they're understanding that they can work through some pain. So that's the role of a corticosteroid injection, in my opinion. We use all kinds of other injectable therapies. I know so there's a technique called platelet-rich plasma injections, or PRP, it's abbreviated, where we take venous blood from your arm, and then it's spun in a centrifuge and separated into the growth factor-rich portion of the blood, which is in this section or segment of the blood that is separated out, and that can be used to, if you inject it into a degenerative joint, that can be really helpful at tipping the scales or tipping the equilibrium back into the joint to not have it be in such a breakdown, inflamed, painful state.
What are you trying to do? Trying to recreate a new healing environment?
Yes, I think that's what the science is still trying to understand that, to be honest.
I feel like when people talk, we'll talk a little bit too about PRPs, and they'll talk about stem cells as well.
Yeah. So, the conversation always begins with PRP because that's the most prevalent, the easiest, has the most research and literature behind it. I think you have to make sure that you're understanding what you can and making sure that you can explain to the patient that they understand what it is, so they understand that it's not going to regrow them or recreate a brand new joint, but it might. What I think it does is it takes the microenvironment, the chemical environment in the joint or around that tendon tissue, and it tips it in a fashion that decreases some of the catabolic breakdown and increases some of the anabolic factors. So it's, the thought is it may slow some of the arthritis that's going on or some of the cartilage breakdown. I think if you use it right with a degenerative tendon, you can actually try and actually get some of those disorganized tendon fibers to reorganize themselves by disrupting it with a needle and injecting these. I tell people it's like tilling the field and then adding some fertilizer to get healthier tissue to grow.
Tendinopathies are tough for us in here.
100%. They are
really
way hard.
So you feel like you give a PRP and then you give some good isometric input or inputs with exercise. That could be a nice combo for somebody.
100%. So every time I talk to somebody and I counsel, I do not ever do PRP in anybody who I haven't met and counseled and talked to, because I expect that I want them to understand what their expectations are, what their role is, because it's not just this magic bullet that you can just stick in somebody and it cures everything. We'd love that. It'd be awesome.
I think
be amazing. I'd love that.
I think that's why people like to talk about PRP and the stem cell, because they think like this is it. It's gonna.
This is the thing.
I don't need to do surgery, and it's
Correct,
gonna heal me.
So that's why I think you've got to make sure, where a lot of providers get in trouble is they kind of overpromise and underdeliver, and it's got to be the opposite. You've got to really say, like, here's what we're going to try and do. You've got some work to do afterwards, because that leg isn't going to get strong from PRP. We need that leg to be strong after, and during, or else this is going to wear off.
Right.
And so I find a huge role, whether it be tendon or joint, when you're doing any kind of what we call biologic injection, whether it be some form of cell-based procedure or growth factor-based procedure, it still falls on them to follow up with some rehabilitation or offloading or things like that. I also use, I have some pretty limited, but I use it, what a lot of folks would call stem cells or autologous stem cells. Now, I want to clarify something. I am very reluctant to want to use the term stem cells.
Because?
So I don't think what we're doing in this country on the whole is stem cells. Okay.
Explain.
So Arnold Kaplan, who did most of the research back in the 90s, that sort of came up with the idea that there were these smart cells in our body that could differentiate into all different types of tissue, and could be harnessed in a way to help heal, reverse, improve the health of a tissue, has since retracted some of his work in saying, I don't think we can get cells from our marrow, from our blood, from our adipose.
Explain before we go forward. With the PRP, we're just taking out blood centrifuging.
Okay, yeah, let's go back.
With a stem cell, the difference is?
Right. So the first thing, so stem cell, what anybody would call a stem cell procedure in this country breaks down into first two categories. One is going to be autologous, which is from themselves. Okay. And the two places we might get that are your bone marrow or your adipose, your fat tissue. The other category would be allogenic or outside the body. And that would be including umbilical cord products, placental products, different things that are sort of perinatal products. And I'll comment on them because the discussion is much shorter. I do not advocate for them at all, 100%. The claims that are made in that realm are unrealistic and not backed in sound science. So yes, there are some stem cells in those, but they are dead, 100% of them. There has never been, let me be clear, there has never been an umbilical cord or placental product that has ever been manufactured or marketed that has a single live stem cell in it.
So it's cool to think of it because here's this blank slate cell,
right.
But
there's so much processing that has to go into taking someone's placental matrix or their umbilical cord blood and then putting it into somebody else to make it safe.
Right.
And so as a result, I mean, I'm not saying they don't work in terms of helping with symptoms, but you're helping with symptoms probably from the growth factors that are also there.
Right.
Okay. So you take this product, it's usually in a vial, it's been micronized into a powder, you reconstitute it, and
this
then it's
isn't
injected.
Legal in this country, other countries do, or it is?
It's all cash.
Right.
So the FDA is trying to semi-successfully shut a lot of these places down because a lot of these products are applied out of clinics that are sort of med secondary. They're not not a real doctor's office. Mm-hmm. They're going to be these small clinics that's all they do.
Right. And
they'll charge you several $1,000s. They'll do the injection, oftentimes with minimal supervision, oftentimes not with any guidance or any kind of real well-vetted skill. And as a result, I mean, people are desperate. People want pain relief, and money's money. They're there. They want to sell it. and they make these claims and they try and make it look like it's a scientific thing by providing these studies, which are, not rooted in very good science. They're often case-based reports that don't have a lot of benefit. And unfortunately, those folks, there's not a lot of recourse, and there's plenty.
We're saying this is with using stem cells from your own body?
No, I'm sorry. This is still on that subject of using the umbilical and perinatal stuff.
Okay.
Yes, I'm going off on this a little longer than I thought.
No, it's all good.
So I don't advocate for them at all, because not only are we not sure if they work, we don't really know why, and we also, more importantly, don't know that they're safe.
Right.
And so, speaking of podcasts, there's been some really excellent podcasts done exposing some of these stem cell clinics that were down, for example, in like Texas and Florida, that were applying these, and several patients became septic. And
God, dude.
Yeah, putting these injections in, a not very good technique, and then they not only didn't get better, but got worse or almost died. And so that's also why I don't recommend.
Yeah, it's like I'll take my shoulder hurting over sepsis.
Totally, because then they're several weeks in the ICU, and that's pretty scary stuff. And then even outside of that, if you're not as unlucky as them, then oftentimes you spent $5,000 on this that didn't really help you very much. So if you're going to consider some form of biologic therapy, I do not recommend that at all. I recommend you use something that is your own tissue. Now, the nice thing about taking someone else's tissue is you don't need to harvest it.
Right.
You literally just inject some saline into this vial, reconstitute it, put it in a syringe, and then put it somewhere. Whereas, into the patient. Now, when you get into your self products, to get bone marrow, you have to do a bone marrow aspiration. To get adipose tissue, you have to do a little mini liposuction procedure, and a lot of people don't have the stomach to want to do that.
Right.
We're really good at being able to do it without much risk and without too much discomfort, but it's still a procedure, takes time. And with that time, there is also some cost. And so as a result, with these also not having coverage, for this, people are having to pay out of pocket for it. And so you have to make sure that their expectations are appropriate, and that you're telling them not what they want to hear, but what is more accurate with reality, and understanding what they can see or get out of it. Now, that doesn't mean that they're not. I would still argue, I don't think that they're improper. I still think that they help people. But if you see someone and they have an arthritic knee and they want to spend $5,000 on something on a bone marrow and adipose injection, then they need to still understand that isn't necessarily going to cure their problem forever. That if it's a good outcome, a good outcome is getting good function, better pain tolerance, less swelling for a couple of years sometimes. So, and I find that I can often get that with PRP injections too, without having to go through a bone marrow aspiration.
This episode of Off Exit 10 is brought to you by Anchor and the all-new Anchor Pro, crafted to endure the most high-performance workouts without the high cost and space requirements of a standard cable machine. Named the best portable cable machine by Men's Health Home Gym Awards, Anchor provides the full functionality of a cable machine in one small space-saving unit. Designed with user-friendliness in mind, Anchor can simply be attached to any squat rack or placed on any wall in your home gym using its intuitive sliding track mount. With up to 65 pounds of resistance, Anchor is built for high speed and controlled exercises alike, from cable presses and rows to chops and lifts. The Anchor has been a game changer for us here at CDSF, and now you can enjoy the same professional quality cable machine in your own home gym by heading over to anchortraining.com and using code CDSF10 for 10% off your order today. Get all the benefits of a cable machine without the high cost and installation fees. Enjoy the portable luxury and space-saving performance of Anchor today by going to anchortraining.com and using code CDSF10 at checkout. That's anchortraining.com, promo code CDSF10 for 10% off your order today. This episode of Off Exit 10 is brought to you by Drink Alchemy. Fatigue and brain fog affect us all, destroying everything we pursue. Whether as an athlete, artist, creator, or entrepreneur, our mind holds the key to performing optimally. By combining the most potent organic nootropics found in nature, Drink Alchemy delivers sustainable boost to creativity, memory, energy, and focus in one epic beverage. Stop pumping your body full of excessive amounts of caffeine and unknown proprietary blends from other energy drinks, and get clean energy from Drink Alchemy's natural nootropics like lion's mane, L-theanine, and caffeine from green tea. Used by Olympians, D1 athletes, MMA fighters, and entrepreneurs, Drink Alchemy has become a huge part of my daily routine, making sure I'm functioning optimally during long days of coaching athletes, running CDSF, and getting in quality workouts myself. So do yourself a favor and ditch the energy drinks loaded with caffeine, other stimulants, and who knows what else, and head over to drinkalchemy.com today. Live with your mind unbound and save 10% off your order by using code CDSF at checkout. That's drinkalchemy.com, promo code CDSF for 10% off your order today. Yeah, is there a scenario where you would say, I think doing a stem cell would be a better option than a PRP for you?
So I try not to steer people one way or the other with these, because I want to be very careful to not influence something that will affect them financially. Right. I'm not a salesperson.
Right. Yeah.
I want to balance more the science and make it as available to somebody as possible. But at the same time, I think there's a responsible use for it. I don't feel comfortable advertising for it. Right. And I think that that kind of makes me feel uncomfortable. I'm not saying it's wrong. There are providers who I respect who do, and that's okay. But it's not my thing. I want to be more medical. I want to be more scientific. Go ahead.
You think with a stem cell injection, it's more of, or from the research that's there.
Yeah.
Just creating this anabolic effect at the tissue versus like, here are these blank slate cells, and these blank slate cells are going to turn into what we want them to.
Correct, right. So if you go in thinking that you're going to take these stem cells out of the marrow or out of the adipose, and that they're going to go in and they're going to be smart enough to say, hey, yo, you go over there and become cartilage, and you go up there and become joint capsule.
Yeah.
I think we're kidding ourselves to think that happens. That has never been shown to happen. And that's part of where Kaplan's work kind of retracted a little bit, is saying, we can't promise people this. It's not going to regrow you a new knee or a new tendon. It's not going to, pull that rotator cuff tendon back down and make it whole again. But I think there is, there are chemicals and there are cells in the marrow and in the adipose that have effect. To dovetail that, he changed the terminology from mesenchymal stem cells, or MSCs, to mesenchymal signaling cells. So you didn't even have to change the acronym. You just have to change the word, in that they're signaling cells. So they're these cells that go in there and signal to the body that they need to put it in a quiescent or quiet or less inflamed state. And one of those, some of those, there's also, some growth factors that are in them that are probably helping more. There's a chemical called IRAP, or interleukin-1 receptor antagonist. We're getting into the weeds here, but that seems to be a very potent sort of anti-inflammatory. If you put adipose in there, there's some collagen that probably gives these growth factors something to hold on to and stay in the joint longer. So I think that there's something to it that is better and has more potency than, say, does PRP. That said, I think you've got to decide what's right for you with talking with that provider who offers that, and understanding also that if you're paying cash for something, there are some extra layers to that, good and bad. Patients are much more compliant with their rehab if they've dropped a couple $1,000s on their procedure.
That's
already.
A good point. You have to look at those variables, because you do the injection, you create that anabolic environment, but then I need to then give inputs to strengthen and re-stress all this new tissue. Yeah. So, I see all types of people. I see people who are, excellent athletes, who are young and old. I've got, I had a gentleman who was a auto mechanic with ankle arthritis, and I remember doing a procedure in him, and we got him to quit smoking as part of the procedural kind of lead up and post, and he's still not smoking. His ankle's a little better, but he's still not smoking. So that's a win.
That's a win.
You got to win there.
That's a win. So I think that you have to make sure you're. I think that it starts and begins and ends with making sure that you're you're being upfront with your patients about what they're getting, and understanding, and it's incumbent upon the provider to inform them, because there is unlimited stuff to read on the internet, on podcasts of people advocating for things on the radio, on TV. It is everywhere.
And people need to learn, and it's hard if you're the general public without a science education. Like, you look at a research article, you want to know who's funding it, what the person's background is that's writing it.
100%.
And it's the same with anything you consume online. Like, what's the source it's coming from? Who's the person it's coming from? What's their bias? Who's paying them? It's a lot. And normal people don't know to filter through all of those things.
Correct. Right. Most people don't have a scientific background. And even ones who do, there's a lot of good stuff out there that looks good until you really dig into it and you read the whole article and they were really selecting, this big selection bias. And people are desperate to believe that stuff is out there. And I'm not saying that it's not reasonable or usable or appropriate. I'm just saying that people need to understand that there's limitations with it.
Right.
I was going to say, with the PRP stuff, it made me start thinking about like Kobe Bryant when he went to Germany and other people. And a lot of people thought they were going to do stem cell, but they went and did PRP, but they did a different form of it called I don't know how to say this word.
Yeah, which was regenikine.
Yes.
So
I didn't want to butcher that.
So regenikine, the difference there is that it is they're usually doing it in Germany, and their FDA does not have the same restrictions that ours does in terms of what they call manipulation of tissue.
Right. I was reading this, kind of said like they can add things to it.
So here we are not really allowed to add things to your own cells or blood or things to then enhance or change them and then re-inject them back in. So you can't take adipose, for example, and use micro-digestion techniques with chemicals to then get to the stem cells that are in adipose. You can't take these, because what they do in regenikine, I think they take blood and then they incubate it with these glass beads and heat, and it's supposed to upregulate certain
I didn't get that far into it.
Well, there you go. I think I gave you the cliff notes.
Yeah.
So I think it's something like that. I've never seen it. I've never had any.
Yeah, it said something about like putting proteins into the blood to help speed up essentially the process of everything. And I'm just summarizing what I read, so don't take this all as like science.
I don't know I don't know how prevalent. I feel like I haven't heard as much about that.
Over
the past few years.
Yeah, it popped in my head when we were talking about like the stem cell to the PRPs and like, what works, what doesn't, that type of stuff. And I remember like distinctly hearing like Kobe Bryant or Alex Rodriguez was another person. Zach Greinke was another one that would.
Tiger might have gone.
Tiger might have done it too, where they were going to Germany to get these things done when there was a form of it that could be done here.
Yes.
And then like the other thing, it said something about like they can spin it for longer, essentially.
I see. I mean, I think that the biggest factor is adding, and there's a certain sort of threshold that we allow in this country with manipulation of that tissue. Mm-hmm. So, it's gotten a little more relaxed over the past just couple of years, but I don't want to do anything that's not untoward, and I don't want the FDA knocking on my door. So I feel pretty comfortable with what we do.
But it was more just like, do you think that'll be something that you could see us adopting?
I think the next step or the next future of things, I think there's a couple of ones that will advance this a little bit. One is going to be, I think we're really close to having the tests that detect the levels of inflammation in our body that are better and more specific to, say, like a knee. Okay. And we can say, and then we may be able to predict through that, if this one cytokine is elevated in your blood, that might let you more respond to PRP first. And now second, I mean, there's some really cool research. This is probably a little farther out, but there's some really cool stuff being done with actually growing stem cells in the lab that are what we call pluripotent stem cells, which is the only source naturally of pluripotent stem cells is in fetal tissue, which we are obviously no closer to being able to get fetal tissue in this country. So the only way to get real, true stem cells that are going to be the quote unquote smart stem cells is to grow them some other way. And there's some techniques that they're doing in research capacity that might make them available to somebody in their lifetime in the next 10 years. I don't know, but
could be longer. We're not
I'm not making any
a timetable
promises.
on it.
No, don't do that.
Do you think or have you seen clinically, or do you think the older as you age, you respond less well to these PRP stem cells? Or is it more just like how healthy you are, how your inflammation levels are, how active you are?
So I would say they're both important. Health to me is more important than age. So, because I have 50-year-olds that look 80. I have 80-year-olds that look 50, right? And we all know them. I think that health is more important than a number. That said, certain things will degrade faster. I think the blood and adipose actually degrade slower than their marrow. So an 85-year-old who's healthy who gets a bone marrow injection will do less, will be inferior to the 55-year-old or the 40-year-old bone marrow aspiration, in that those cells are older, the signaling cells that we alluded to are older, there's less growth factors. Now, it doesn't mean that it's not okay to do. I just think that the effects will be lower. But there's not the only real absolutes to not doing these are an active cancer and an active infection. So those are the main two exclusionary criteria. If you are undergoing treatment for cancer, you should not undergo any of these treatments. If you have an active infection, do not undergo these treatments.
Have people ever asked you, because I feel like this is all on the internet now, about BPC 157?
I have been getting some more questions about that, and peptides in general. I am yet to see any convincing data on any good studies, and what our sort of our main source of recommendation would come from a study that's, a double-blind randomized controlled trial that gives people these and gives people something that they think it is, and seeing if there's an actual tangible objective or subjective benefit. Obviously, I'm under the impression that BPC is a peptide, I think, made from gastric juices, so gastric stomach juices, and I think it was originally.
I'll look it up. I believe you're correct.
And I think it was originally made to be like a peptide that was supposed to help sort of gut health. It was originally found sort of by GIs and sort of using it to help control.
Just look up BP 150.
BPC 157.
Yeah,
I'm pretty sure it's a gastric peptide that that was made to try and help sort of reduce ulcers and inflammation in the gut. And then they've tried to sort of pivot that over to being, something that you use to help heal.
Yes, gastric
injury.
Long ass word.
We're giving you the words today, Paul.
Gastric pentadecapeptide.
Yeah. So
nice job, Paul.
There you go. Killing it.
I mean, it's pretty much how it luckily, it's like how it's
phonetic,
right?
Phonetic.
Yeah. That's the word I was looking for.
There you go.
As long as you're not clipping your toenails over there, I'm good.
Oh, I already did that earlier. Don't worry.
Yeah. So I'm not ready to recommend it yet. For me, things are, number one, is it safe? I guess it's probably safe. I don't know. I haven't seen anything that's been bad. That's
not a hell
one.
yeah. So therefore,
but it's definitely not a hell yeah. No. So for me, it's a no. But if you want to dump a little bit of money in it and see how it goes, because I'm sure it's not cheap.
Yeah.
Fine. But I don't know that I'm ready to put my cart on that horse yet.
Yep. You see youth athletes as well, like high school athletes in
Definitely.
your office?
Yeah. All ages.
Okay.
I'm all ages. I see down to elementary school and single digits and all the way up to, I got a couple 100-year-olds. So
do you feel like you've
shout out to the 100-year-olds?
Yeah,
shout
out, man.
Yeah.
That's amazing. They're just out there doing stuff.
Oh, dude, it's awesome. Everybody's goals change. That's the philosophy I have. I have that everybody's an athlete, whether they're 102 and they're trying to be able to walk around the block,
right?
Keep living in their house, drive, or I've got a 5-year-old who wants to, run the gym class mile as fast as he can, or I've got a 15-year-old who wants to try and throw faster or run faster or college athletes who want to try and, make the next step. So yeah, every level, masters athletes. I got 70-year-olds who sprint and hurdle. It's awesome.
Yeah.
Yeah.
Do you feel like, because obviously I started doing this 2011, and I've seen just a shift from kids doing 3 sports to 2 sports to 1 sport predominantly, or 2 and 1. And I feel like it's too far gone where we can't stop it. We're in the world of kids specializing at earlier ages due to college scholarships and competition. Is this something we just have to now learn to deal with and manage? Like, it's not going to get changed.
Well, I think it's interesting because I think you can come at this from 2 different angles. I mean, I think that you're right. Like, people are going to continue to sport specialize, and kids who want to play year-round a certain sport, I mean, I don't know that we necessarily need to stop them from doing that. I mean, I think that as long as they are aware that their risks are higher for injury, for overuse injury, for doing the same sport month in and month out. But if that's what they love, if they love soccer and they want to play soccer year round, if they love swimming and they want to swim year round, I don't know that I'm ready to stop them from doing that. But I think that if they're doing it for the goal of trying to make it to the next level, meaning a college scholarship or professional, I think they all need to read the book, The Sports Gene by Joel Epstein, which is a very easy and decent book to read that I have loaned out to multiple friends, colleagues, and parents, because it basically says, in a nutshell, in many very fun and interesting stories of athletes over the years, that professional athletes are born, not made. And if you've got a kid who has an amazing amount of talent and they're going to be a professional athlete, they'll be a professional athlete if they want to be that, if that's what their drive and their passion is. You're not going to put the professional athlete in a kid by having them play a sport year round. So if they love it and that's what they want to do, cool, go for it. But if they're looking to try and that's their path to try and make a college scholarship, and also where's the motivation come from? If it comes from a kid, I think it's probably less pathogenic than it is if it comes from a guardian.
I think the forced sport specialization, where as opposed to the volunteer sport specialization,
because
that's the way I would
you're
put
right
it.
about, this being the sports gene or you're born with it. Because we see kids in here, some kids, it's like, you got a Hemi, you're a beast, you're always going to be a beast, your skill level's so high. Mm-hmm. When you come in here, I just want to make sure you stay healthy.
Yeah.
Like, we could just do a couple things in foam roll and you'll be the best player on your team. It's the kids who got like the V4 and they're not super explosive and fast. Their movement quality's not great. It's like, okay, well, like, we got to push this envelope a little bit more to help you make your high school team. Right. So you can have that experience.
Well, and it reminds me of when we had Dags on and he talked about
Guilderland guy, you know Dags?
Oh, well, my son knows him better than I do.
Okay.
My son plays basketball and he's worked with Dags a bit.
He said, he's like, I like to believe that me being, working with Kevin Herter, helped him get there, which it probably did. But he's like, he would have found another coach and he would have got there. He would have been there anyway. I'm not the reason he did. I was just part of it.
Dags gave the best college. Jordan, go to our YouTube, find find the Dags clip where he talks about this is the best, as well said as I've heard this ever.
Which
he talks about kids playing for scholarships versus the process.
And how like the scholarship is the byproduct, not the end goal. It's the byproduct of everything that you do.
Yeah.
That's probably the same thing, right? Like, kids are going to get the scholarship. They're going to be an elite athlete.
Right.
Not necessarily that they're going to work hard enough to earn it.
This is what Jordy's going to play. It's powerful. Every kid should hear this. Dag says it so well. You trying to find it, Jay? Okay.
Yeah, the big thing with that too, though, like going off what you said, is like that doesn't mean like don't sit there and try to become a professional athlete or try to work your ass off to do that. It's more of like, there are going to be certain limitations for each individual, whether it's that person that is going to be the professional athlete or that person that's going to be the scientist that discovers something in stem cells.
Right.
Like,
right. And I mean, most of them are they've got a high score, 9 or 10 out of 10 in drive or in talent.
Right.
It's when you've got both, that's when they're that rare unicorn, right?
Mm-hmm. Yeah.
So most of the kids hover at, if they're 9 or 10, they're a beast, but maybe they don't feel that compelled to be that want to pursue that, right?
Yeah.
I mean, if my, some of my kids had, the level of talent, that they have their drive, some of my patients would be tremendous. But
yeah, we've said in here before, if you could take this guy's skill and this guy's work ethic, oh my
put
God.
them together, you gotta,
right?
There's so many times that I see that, I'm just like, oh, God.
Jay, did you find it? Yeah, here it is. Turn it up for us if we can hear it. You should be playing the long game with kids.
Yeah.
Right? That's what it's about. And there comes a time to ramp it up, but not when you're in 6th, 7th, 8th grade, 9th grade, 10th grade even.
Yeah.
But it's the trickle down from the business, like you said. The Division I scholarship being a business, and then you see this trickle down.
Yeah.
It's interesting. I like to have these conversations with parents, players, coaches, people in different fields. And like for on the basketball side, I try to have this conversation with players, and I say, if you're in 9th grade, let's say you're in 9th grade and you're on an AAU team and you don't make a shot the whole season. You don't make a shot. Next year, your sophomore year, high school, play JV, varsity, whatever, you don't make a shot. So you've made 0 shots in a year. You go to AAU of your sophomore year, going into your junior year, you don't make a shot. You still haven't made a shot. You stink. You come back your junior year of high school, you average 18 points a game. You kill. AAU season that year, same thing, 18 a game, you kill. Senior year, 18 a game, you kill. Is any coach that likes you, college coach, going to turn to you and say, well, you didn't make a shot when you were in 9th grade, we're not going to take you? And the answer is always like, no, they're not going to say that. I said, so then who the heck cares what you're doing in games when you're in 9th grade, when you're in 10th grade? Yeah, you want to do good. Yeah, your teammates are probably going to hate you if you don't make a shot for 2 years. But if you play, like you said, the long game and understand like, you're not playing for a scholarship. You're actually, to be honest with you, you're never actually playing for a scholarship. A scholarship is a byproduct of how productive and talented and your potential moving forward. You're not actually playing for, there's nothing that you can do in particular that can get you a scholarship. It's a combination of things over the long term and what you do consistently. And so like when people figure that out and they can say, oh wait, I can just work on getting better and not being scared of failing. Those are the players that can, that take the jump. And those are the parents that can take a breath and be like, oh, wait a second. We shouldn't be like fighting at a 7th grade kids game.
Yeah.
I use that all the time with kids in
I
here.
love that.
I use that. I say that all the time with kids in here. I'm like, whether especially we had kids got cut or whatever, I was like, listen, or that they didn't make the level of team. They tried out for JV, maybe they made freshmen. And I'm like, just get your reps in. I'm like, that's what it's about right now. Nobody's going to care that you didn't make the JV team as a freshman. Not a single person. The only person that is, like you brought it back before with like running, the only person that cared was you.
Yeah.
Nobody else cared that you didn't make it. Maybe your parents might have
they cared because you
cared because you cared, or they were that parent that was a little too intense. But for the most part, nobody cares that you didn't make that team. They care like, okay, are you having fun? Are you getting your reps? And by the time you get to senior year, how do you feel about that? Like,
yeah, no, I love hearing that as a parent more than almost as a doc, right? Like that's just great. Dags is so gifted with his words and that, and gifted in a lot of ways, but that's pretty exceptional.
Yes. Yeah. Listen, shout out to Guilderland.
Yeah.
To both of you.
All right.
Big Guilderland podcast today.
Oh, man.
Good stuff.
No, man, Todd, I appreciate you doing this.
Oh, man, this was fun. This has been fun.
Yeah,
I've enjoyed this.
I told you we needed over an hour.
No, you were right. Yeah. Right on, man.
Pretty much every time. I don't know if we've done one under an hour.
Once. But the person was like, I got to get out in under an hour.
Oh, yeah, that's right.
Yeah.
I don't remember who that was, but
it was somebody. But we did okay.
No, this is fun.
This was fun, man, and we didn't swear. Good job, Paul.
Yeah, I did say one, but it wasn't that bad. It was technically a body part. All right.
Yeah. No, this was good and clean. I know some of my patients have probably heard me use some choice language, so I'm happy that I was able to put out something into the media verse that I didn't have to clean up.
Yeah.
Yeah, man. No, this was fantastic. Todd, anything you want to plug before we jump off right here?
Man, I wish I'd given that some more thought. No, I guess just, I think the biggest thing for me and where I struggle the most with people is get somebody in your life who you can trust and help to bounce ideas off of that is different from you and knows different things, not necessarily just more, but just different things. And we're all better if we've got someone around us who who we can bounce off of, who's not going to just say, yes, sir, or that sounds like a good idea, and always acquiesce. So I think if you've got somebody who can be around you and give you advice, whether that be a partner or a friend or a doctor or a coach, someone different can help give you another point of view, a DAG's point of view, if you will, of how you should be viewing, how you approach your parenting, your coaching, your medical, your health choices. Because where I struggle is just the people who come in with just so much misinformation, and I ask them how I can help them, and the first thing they launch into is all the 13 different things to Sunday they've been told by other people. And I said, I don't really care what other people have told you. I want to hear what you are going through. Yeah. And you got to have people who can listen. So, they're out there. Sometimes you got to find them. And I think of one. I'm one who I think always listens, but everybody has bad days. So you got to give people sometimes more than one chance. So, but good luck on navigating all that. But always finding someone who can help you with that can really help open a lot of doors.
I think that's powerful. I think anything. Awesome. I think any person, whether it's healthcare, whether it's you financially, or any other aspect of your life, it's like who's helping you. You should be able to sit down and have conversations with them, and they should be listening to you. And maybe you don't start at the same viewpoint, but you're working your way to getting on the same page so you can help each other.
Right. Absolutely.
Yeah, man, I just love it. Cool. Todd, I appreciate you. This is fantastic.
Thank you.
And we'll catch everybody next time. Thank you.